class, Dr. Nordstrom here. I'm going to be presenting on cardiac disease for your Phys-Oc 2 course. You are required to read Chapter 44, which is actually cardiac and pulmonary disease. We will be covering pulmonary disease diagnoses next week, so primarily wanted you to focus on just the cardiac diagnoses, but in saying that, I need to make sure that after you read up to all that is cardiac, you also skip the pulmonary ones, but then progress to the end of the chapter because it will go over cardiac interventions and cardiac evaluations. So the objectives that we hope for you to achieve at the end of this lecture is that you're going to have a better understanding of the cardiovascular function, and specifically how heart rate and blood pressure can impact your client's ability to participate and engage in occupations. You should be able to identify the significance of ischemic heart disease and valvular disease of the heart, and also be able to note its potential impact on occupational performance. We hope that we can better help you understand the difference between modifiable and non-modifiable risk factors and how those can be impacted by the context and environment. We're going to also focus on identifying signs and symptoms of cardiac disease and the proper course of action. Identify and educate your client on cardiac sternal precautions. Identify modifications for activities of daily living for precautions. And demonstrate methods for determining heart rate, blood pressure, and calculate RPP, which is rate pressure product. You know how much I love case studies, so I wanted to reiterate the case study that was specifically utilized for the cardiac diagnoses regarding Rudy. I think it's important that when you're reading the content that we ask you to read in this book, that you really do focus on the case studies, because it gives you an opportunity of a real client with true diagnoses, great past medical history, personal life, prior functioning prior to admissions, but then also what does the occupational therapist do and what are the goals. So it allows you to see how a diagnosis is actually incorporated through the entire OT process. So I want to talk a little bit about Rudy because this was in the beginning of the chapter, but then it also expressed interventions and approaches throughout the cardiac disease chapter. So he's a 64-year-old male. He had a past medical history of diabetes, but also was aware that he was having some issues with his heart valves. He was married. He worked full-time as an executive desk job. He runs 3 miles a day, can be under leisure or health management. He was admitted to the hospital due to complaints of sudden fatigue, shortness of breath. Vitals are as is. Heart rate was 140 beats per minute. Blood pressure was 128/70. Respiratory rate was 20 breaths per minute, and his O2 sats were 93. He was diagnosed with atrial fibrillation and underwent an aortic valve replacement and cardiac ablation. Was also has sternal precautions due to the procedures that were done. For an occupational therapy evaluation, the results indicated how he did with bed mobility, transferring to the bathroom, toileting. He complains of min pain, impulsivity, and was not following cardiac sternal precautions. His goals was to be able to return and do everything he did prior to his diagnosis. He wants to be able to return to work. He also wants to be able to have an intimate relationship with his wife. At the time, she's very nervous about him and being able to do any sexual activity because of his cardiac condition. And he also wanted to resume alcohol consumption, which was not mentioned, or he did not provide that information to the physicians in the ED, but did open up to the therapist about it. So for us to get started, it's really important to kind of understand the anatomy and the circulation of the heart. Again, this should be content that you reviewed and practiced in anatomy and neuroscience. So I'm going to briefly go through what I feel is the priority of what you should know. The picture to the right gives all the anatomy components of the heart. And then I also, at the very end of this PowerPoint, have provided you with a video on the anatomy, the circulation of the heart as well, which will go into a little bit more depth. If for some reason, because this is a PowerPoint that's recorded, it is not going to actually be able to play when I make this recording, I will post the link so you could access it after. So heart and blood vessels work together, and this is able to maintain a constant blood flow throughout the body. It is located between the lungs and is kind of averaging the size of a fist. Now remember that there's different parts to the heart that have different functions. So the right side of the heart is going to pump blood, pumps blood from the body to the lungs. So all the blood that comes from the organs that has carbon dioxide in it is going to now get pumped in the right atrium to the right ventricle and then to the pulmonary artery. There, it will then be reoxygenized, and then the left side, it will enter back through the left side of the atrium and then go to the left side of the ventricles, and it will get pumped oxygenated blood from the lungs to the bodies. There are two chambers. Those are the atriums and the ventricles. And there are input valves and output valves. So the input valves, there's a mitral bicuspid. This you can find over here, and it's in between the left atrium and the left ventricle. And then we have a tricuspid valve, which is between the right atrium and the right ventricles. Our output valves are the aorta. Trying to find that cursor again, disappears on me. And then we have the pulmonary artery. The heart itself also is an organ which requires blood supply and oxygenated blood. And we have the left anterior descending artery and the right coronary artery. If any of this is not familiar, or you feel like, okay, I need a refresher, please do so, and please watch the video that I will provide with this. So again, how does the conduction of the heart work? So again, the heart has its muscle. It's called the myocardium. There's multiple layers on top of that, which we'll get into more detail in the video that I have provided. But there are specific tissues that act as they're the electrical conduction systems. And what that means is that the nodal and the Purkinje tissues provide an impulse that allows the heart to contract and relax. This allows the blood flow to enter through into the heart to the lungs, and then from the lungs, then through the atrium and ventricle back out to the body. It is a systematic electrical system that all chambers work in quality. So it's a nice smooth motion. It allows for you to have a regular heart rate, heart rhythm. There is a synatrial mode, which is allows for the electrical impulse to originate in the right atrium to trigger that electrical conduction. So it starts in the right atrium. This impulse is going to travel along the atrioventricular node, then go through the bundle of His, then the left and right bundle branches, then to the Purkinje fibers. And this is occurring 60 to 100 times per minute, this contraction and relaxation. So some primary cardiac diagnoses that we're going to discuss. I'm going to give a little bit of input here, and then some of these I go into more detail throughout the presentation. Hypertension is one of the most common things that can lead to further cardiac problems. So it is high blood pressure, and it is determined by a resting systolic blood pressure if it's about 140 or more, or a diastolic pressure that is 90 or more. And again, remember, we're dealing with the adult population, so I'm giving you the averages for those. Normal blood pressure is different for a pediatric population and even a geriatric population. So when we're talking about classifications in normal blood pressure, we're looking at to be about 120 or a little bit less for systolic blood pressure, and at least around 80 or a little bit less for diastolic blood pressure. Someone who is considered prehypertensive, they're going to be running around 120 to 138 systolic blood pressure, or they will have 80 to 89 diastolic blood pressure. Stage 1 hypertension, we're looking at 140 to 159 systolic blood pressure, or 90 to 99 diastolic. And stage 2 hypertension, we're looking at 160 or more, or over 100 or more for diastolic. So hypertension really increases the risk of heart disease and stroke. These are the top 2 leading causes of death in the United States. Blood pressure typically increases with age due to the stiffening of the arteries or a development of a small vessel blockage. There's other causes that could also create hypertension, and those are alcohol consumption, non-steroid anti-inflammatory drugs, corticosteroids, cocaine, oral contraception. It's also known as the silent killer. It is a genetic composition to it as well. It does run in the family. There are recommendations to be able to control it with being on a weight loss program, decreasing the amount of sodium intake in a diet, having regular exercise, limiting alcohol consumption, and completely stopping smoking. Some medications that are provided for when we're into stage 1 or stage 2 could be some diuretics, again, decreasing sodium, having clients go on to beta blockers, which will help minimize the cardiac workload and dilate vessels so we can get more flow through there. There's also lisinopril that can be diagnosed to help relax the vessels. Also stress management programs. Coronary artery disease is the most common cardiac-related disorder. It is due to ischemic diseases and due to arteriosclerosis and plaque that are formed on the coronary arteries, which end up narrowing the vessels over time, so it could decrease or possibly occlude the blood flow to the heart. It's typically higher in men at a younger age and then in women at an older age. There's a question about the hormone estrogen playing a role in that for postmenopausal women. There's other reasons that could also cause this to be aware of, and that's having cholesterol, high cholesterol levels, difficulty with managing diabetes, overweight, assessing someone's activity levels, and again, drinking and smoking. There are different tests, you're going to find out about them, that are non-invasive tests that can also give diagnosis to each of these cardiac conditions. We're going to talk a little bit about AFib, and that is an arrhythmia, and it's a disturbance in the normal rhythm of the heart flow. It can be benign, or it can cause for immediate life-threatening situations. AFib is one of the most common sustained arrhythmia conditions. And again, a normal heartbeat begins with that electrical signal that I told you earlier with the sinus node and that right atrial. But during AFib, these signals are going to be fired more rapidly, and so it gives that irregular heart rate. This could eventually cause a blood clot that could increase pools of blood in the upper chambers. So clients will display an uneven pulse when you're checking, or they can complain of a racing or pounding heart, or that can be also observed. There's some feelings of shortness of breath, some dizziness and fatigue. They could possibly feel faint. very similar to symptoms associated with a stroke. Congested heart failure is a complex diagnosis that occurs due to impaired structures or functions of the ventricles. So the heart's ability to pump the blood to the body and provide to the organs is impaired. There is a difference, though, from a left ventricular dysfunction versus a right in some of the clinical findings that you would see. So if a client was suffering from a left ventricular dysfunction, typically they would present with fatigue, shortness of breath, and pulmonary edema. If somebody is suffering from a right-sided dysfunction with congested heart failure, then all of a sudden that is very notable with peripheral edema. So the lower extremities are quite swollen, possibly hands are swollen. The left or right side of the heart may be a result of a systolic dysfunction, and the heart is unable to contract efficiently and effectively, or the diastolic function when the cardiac heart muscle is unable to relax. So there's complications with those. Let's see what else I want to talk to you about this. Sometimes the onset is acute, or it can progress slowly over time, being considered more of a chronic condition. There are different classifications, and when we have lab, we will go through this and some other, the MET levels and the Borg assessment. But there are 4 classes for congested heart failure. Class 1 means that there's no limitations. The client can perform normal activities, and they will have no fatigue or difficulty breathing with exertion. Classification 2 means the client will have mild limitations with just everyday ordinary activities and possibly some difficulty breathing when ambulating more long distances or climbing flights of stairs. Class 3 means the client has moderate limitations with increased activity demand. So they're doing above what they normally do and they're having more limitations. They will definitely present with fatigue, difficulty breathing, ambulating short distances, and then climbing one full flight of stairs. And then severe is class 4, and that's having breathing difficulties at rest or with minimal exertion. So again, when we have our congested heart failure, we're going to kind of put them and decide what class are they in, and that can be determined before us. But then be aware if they are given a classification, what that means to you from a therapeutic standpoint, to be able to judge the graded activities you're going to have them do and the type of interventions you're going to provide for them. Myocardial infarct is pretty much the same as a heart attack, and it's irreversible damage to the heart based on a coronary artery obstruction or prolonged lack of oxygen to the tissues. We're going to get into that a little bit more coming up as well. An acute MI does have their own categorization, like based on the levels that they're at. So a type 1 acute MI means that it's due to ischemia. It is primarily a coronary event, whether it was due to arteriosclerotic rupture or coronary dissection. An acute MI level 2 is caused by ischemia, but this is more due to a coronary artery spasm, which is decreasing the oxygen supply, and also could be due to hypertension. Acute MI3 is related to sudden cardiac death. Acute MI 4 is linked to our percutaneous coronary intervention, and we'll kind of go over that in a few minutes, a procedure, or a stent that now with the thrombosis. And then 5 means that an acute MI number 5 stage is associated with a CABG, a coronary artery bypass graft. So let's talk about ischemic heart disease. You learned about ischemic when it came to CVAs and the lack of oxygen to the brain. Well, an ischemic heart disease is a deprivation of oxygen to the heart. It could be partially or completely blocked. The most common cause is a coronary artery disease. It can develop over time without really showing any type of symptoms. Basically, the internal wall of the artery ends up having an irregular shape as the picture across the way here. And what happens is we have plaque and platelets that build up and fatty deposits. And so that causes what's called arteriosclerosis. And that means that that is a disease process where the artery is basically getting into a very narrow space for blood supply. So if you look here, this is the only amount of space for any type of blood supply to go through that artery due to all of this excessive deposits. So this is telling you that these are going to cause then that small way is going to really limit the amount of blood that's able to pass through it. Someone else, another term that's quite common, which is a precursor to even more ischemic heart concerns, is angina, and that's agina. You'll hear people say it two different ways. It's that squeezing or tight chest pain. It makes it feel like your chest is full. It's not always localized to just at the chest. Sometimes people will report that it radiates down the arm. A lot of times you'll hear that it radiates to their back and their neck. Again, this is a warning sign that something is going on. Typically, the doctors will treat this with some medication and rest, typically a nitroglycerin, just to be able to see, okay, is there something more to this? Because if it's just angina, then it's just going to resolve itself with rest and medication. But if the chest pain is not relieved and persists, I should say, that means it's more or less probably a myocardial infarct, which is a heart attack. Here, the blood flow to the heart muscle is interrupted and it stops pumping, and your client will go into cardiac arrest. Again, for medical treatment, they will provide the client with medications, fluids, and then that client will then be restricted for 6 weeks of activity. The occupational therapist interventions will consist of seeing how and teaching the client to participate in self-care at a specific level of activity. So realistically, we need to monitor their vitals. We need to see how they can participate and teach them safely how to take breaks, look for signs of fatigue, and utilize energy conservation techniques. Another ischemic heart disease is congested heart failure. This is a disease that is usually over time. The heart starts to become weaker. It's unable to pump effectively, and there's usually fluid backup. The heart, there's a diagnosis of cardiomegaly, so the heart becomes enlarged. The physicians, as far as medical treatment, the clients will be given diuretics because there will be fluid overload. They will be given low sodium diets, and they will have fluid restriction. And congested heart failure cannot be cured. So being aware of this, as far as an occupational therapist, we're going to need to monitor and again address safe activity levels. But most importantly, we need to make sure that if someone is on a fluid restriction in a specific diet, we need to make sure family and client are aware of that so that they're not bringing in additional food, or whenever the client is thirsty, they're not going above and beyond the fluid restriction requirements. Occupational therapists, their interventions will consist of graded self-care tasks as well as provide preventative programs for stage 1 and stage 2. Participation grading will occur for stage 2 and stage 4 for congested heart failure. So that's that stage 3 and stage 4 is they're having a lot more difficulty, a lot more symptoms while performing activities, and that's why we need to grade the activity so they can be successful but also exhaust themselves. This is a picture of the classification as well for congested heart failure that I discussed a little bit earlier in this presentation. Again, keeping in mind that we have 4 classes, and the first class you're not going to have any symptoms. The client can perform all their activities the same. Class 2, they might start to show some limitations with physical activity, but there's nothing there at rest. Class 3, we're starting to be more aware, more moderate amount of limitations, and these are based on activities that are not your typical activities, and then they are still comfortable at sleep with rest. Class 4, they really are unable to carry out any activities, severe limitations, and symptoms start to present at rest. And these are the New York Heart Association functional classifications. So valvular disease. This is where the heart valves that control the flow through the heart are impaired. It could be damaged by disease or infection. And there are 2 complications. One is volume overload and one is pressure overload. So looking at the picture in the top right corner, here is a normal heart, and so the flow is going from the left ventricle to the aorta, and this large arrow shows the normal amount of flow that's going to be able to go through that valve. Over here, we are looking at a much smaller opening, which is going to decrease the flow to the heart. So volume overload means that fluid is accumulating in the lungs. It's causing shortness of breath. It's going to increase the potential to have AFib. It's also going to cause irregular and ineffective contractions of both atriums. The heart starts to slow down. Blood clots may develop and form in the ventricles, which at once released could cause a CVA. Pressure overload is due to aortic stenosis, which is the narrowing of the left ventricle. Oh, it's the narrowing, sorry. Aortic stenosis is the narrowing of the aorta. The left ventricle is going to have to work really hard to be able to open up that valve because it's enlarged, and then that cardiac output is going to be decreased. You also will have a ventricular arrhythmia. This could also cause cerebral insufficiency. So your clients might demonstrate confusion, syncopal episodes, and there is a possibility of sudden death. So medical treatment here is physicians are going to have to surgically repair or replace those damaged valves. So there are risk factors that we want you to be aware of. The non-modifiable ones are ones that cannot be changed. So heredity, genetics can be risk factors for any one of these cardiac diagnoses. Gender also plays an influence, as well as age. Usually more cardiac concerns occur later on in life, but some of these, specifically hypertension, is known to impact males at a younger age and then females at an older age. Modifiable factors means these are things that can be controlled, but the client has to be compliant and well educated and seeking resources. So high blood pressure is a risk factor but can be controlled based on diet and medication and activity. Cigarette smoking needs to cease immediately. Cholesterol levels, if they are considered high, those can also be adjusted by proper nutrition and exercise. Active lifestyle can also make a difference. Some contributing factors that could increase the risk for cardiac problems is diabetes, most especially uncontrolled diabetes, stress, physical and mental, and obesity. Signs and symptoms of cardiac disease. So these are some things that your clients might report, or you might be aware that they have a cardiac condition. It might just be hypertension at this point in time, but then they might report some of these. So you do need to be aware of what they are, once, while you're reading the charts, and 2, so you could properly document in your own documentation. So again, we talked about angina with being chest pain, that tightness, that aching, that burning. Sometimes people have complained about it feeling like indigestion or choking. It can be localized or radiating. Dyspnea is shortness of breath with activity, or it can happen with activity and rest. Here, the respiratory rates are usually more than 30 breaths per minute, and this could be a sign for acute congestive heart failure. Take into consideration that a healthy, normal heart with activity will increase respiratory rate, heart rate, okay? We're talking about a client who these are typical activities that they were able to do, and now these are new signs and symptoms that are occurring. And typically it's usually around more than 30 breaths per minute where we start to question a concern. Orthopnea is when a client is having difficulty breathing, specifically lying in supine and at rest. So in this case, they would usually use multiple pillows for them to be able to sleep comfortably. Nausea, vomiting, signs of feeling sick to your stomach. Diaphoresis is when they're feeling cold and clammy and sweating. Fatigue, meaning general feeling of pure exhaustion. Sometimes there might be cerebral signs where someone might complain of confusion, dizziness, ataxia. Syncopal episodes, which will be indicating that the brain is not getting enough oxygen. Orthostatic means that there is some drop in systolic pressure. So usually it's going to be about more than 10 mmHgs with the change of position, right? So we might, let's say a client starts with their blood pressure and then all of a sudden it drops 10 numbers when you go from supine to sit, okay? You want to then see if that's able to regulate. If it's not, and then you test it again and it continues to drop, they're going in an orthostatic hypotension episode, so you need to put them back to supine. And again, we want to see there should be a slight change in numbers from change of position, but if it's that large amount, more than 10, and it's not able to regain back to normal once they have been in that position for a few seconds to minutes, then we need to go back to the original position. And we usually take measurements supine, if they can tolerate it, to sit, and then to stand. Medical management. So your book does a really nice job going over medications, and you should familiarize yourself with some of these terms. Again, before someone is given a cardiac diagnosis, if they're complaining of some shortness of breath or a little chest discomfort, they'll probably be given some aspirin, and the doctors might start with just some oxygen alone. If someone comes in and they're really complaining of severe chest pain, then they will be given aspirin again and oxygen, but this time the doctors are going to give them nitroglycerin. And so what that's going to do is that's a vasodilator, so that's going to relax the blood vessels with the hope of getting an increased blood supply to all of the organs, and it's going to also help to reduce the heart from working so hard. And so hopefully that medication and that treatment alone will make this chest pressure, chest pain subside. If the chest pain does not subside, it could be a myocardial infarct. And specifically if a client has an acute MI, then they will be put into ICU for 1 to 3 days with monitoring, medications, and limited activity. The occupational therapist will get an order, and the PT as well, to be able to come in to work with that client once stable. It is our job as OTs to be able to monitor the response to activity. So we will go in, see the clients. Even before I enter the room, there's all the monitors are in one place with the monitor tech reading them at all times. And I can check the numbers even before I enter the room. I usually write them down so that when I go in and they just get some auditory stim and try to work with them a little bit. I want to see if the numbers go up and change. And then I also want to keep track of if I'm having them move, do any type of movements with their upper extremities or bed mobility or self-care, how much are those numbers changing? A lot of times we will have specific parameters that we have to maintain, that we need to make sure the heart rate does not exceed a certain number, or the systolic or diastolic pressure does not exceed or decrease a certain number. So in ICU, again, it's educating the client on the disease process, monitoring the response to activities, documenting the changes in any vitals, and then going over some energy conservation techniques, pursed lip breathing, lifestyle modifications, and risk factors. So things that you do want to be aware of is that some of the medications that I've put here, I listed off specifically for arrhythmias. They might be given a beta blocker, or they might be given Lanoxin. Again, these are going to decrease that heart rate, and so it's going to also decrease that cardiac output, which will then lower the blood pressure. So each of the medications in table 4.2 have a purpose. So some of them are antiplatelets, anticoagulants, right? So Coumadin and heparin are given because those are blood thinners. Warfarin is also a blood thinner. And then some of them are given to be able to lower cholesterol. Some of them are given as a diuretic, Lasix, and some of them are given as a vasodilator, nitroglycerin. So the chart goes over about 11 common names, their purposes, and why they're being prescribed. Again, to familiarize with the medication and the purpose of the medication. You're going to be working with a lot of patients on health management, managing their meds, and they might get confused as to why they're taking something. So making sure that if you're working with the client and you are familiarizing yourself with the pharmacology, or you have a little cheat sheet that kind of goes over the basic common medication that a client needs to be on and why. There is some non-invasive heart disease technology to provide diagnoses. Some of them is just getting blood work done and looking at LPs. This gives you an example of a normal LP is going to be less than 30 milligrams. A borderline cardiovascular is going to be between 30 to 50 milligrams. And then an elevated, which has a higher risk for cardiac disease, is going to be more than 50 milligrams. So when you're getting blood work, you're getting tested for cholesterol and all of that. So take a look and see what yours are. And then your clients will have that as well to be able to indicate we might need to do further testing. There's a test called an electrocardiogram. It's also known as an EKG, where limbs and electrodes are placed throughout the person's body, their chest, and then their lower extremities. And this is going to pick up electrical pulses, and then it's going to then transcribe those onto a paper. And it doesn't take long. I think the longest part of this is the setup, which is actually hooking up all the electrodes correctly. Then the technician will press a button. The client will remain there for about 5 minutes, and then the results will get printed, and then they remove all the electrodes. And this will let the doctors know how the heart is pumping, the electrical components of the heart, and giving you different rhythms if you see them. Then there is a stress test. That's the picture below. This is one specifically with a treadmill, where again the client will have electrodes placed throughout their body. Then they will have to specifically stay on a treadmill that will increase and decrease the speed of the treadmill as well as the height, to see how the client's electrical impulses are doing with environmental stresses added to them. Sometimes they can give somebody medication that would indicate as if they were also running, if they were unable to run on a treadmill, to see how the heart responds to those. Another non-invasive test is a Holter monitor test. This is a portable recording of your heart, and sometimes if clients are complaining of certain symptoms and it's not appearing on some of the other tests, this is something that someone can wear for a designated set of time, for 24 hours up to 72 hours, up to a week. and they have this attached to them, and they have certain protocols. There's another version, so the one that they have for Holter monitors have the electrodes, and there's another one that is like a device that goes on the back of the person or the front part of the person as well, and then can be removed just for showers and then put back on. But this is a nice way to be able to monitor the client's heart rhythms and then see at what points it is being affected. They also have a cardiac MRI, which is non-invasive, but will really give a great picture of the overall function of the cardiovascular system. And during this procedure, it's about a 45-minute procedure where the client is put into an MRI machine and then is asked to hold their breath at different times and for different lengths to put stress on the heart to see how the heart reacts. Some surgical procedures that you should familiarize yourself with, because you might see that a client had these. So be aware of, if they're going for a procedure, if they have any questions that you can address, or if they've just returned from a procedure, depending on which ones. You will have limitations for when you can participate with the client for some of these tests, for sure, and the nurse and the doctor will post and notify you with those limitations. Sometimes a client needs to be in flat bed rest for 24 hours. There's going to be limited movement and motion with a pacemaker, defibrillator, and specifically sternal precautions with a cabbage. Let's start with the first one, which is a cardiac catheterization. So that's just an insertion of a catheter that's going to go into the chamber of the heart, and it's going to be used to take a look for specific diagnostic or interventional purposes. We can have a balloon angioplasty. So if those arteries are clogged, they will, this is also referred to as a percutaneous transluminal coronary angioplasty. And this catheter is going to go through the femoral artery, and then it's going to have dye that's injected into it so that the doctors are able to pinpoint the exact site of lesion. Once they get to that location, they're going to then inflate a balloon, and then with that inflation, the goal is to allow for the flow of blood to increase. If the balloon alone was able to do what it needed to do, they will leave it at that. Otherwise, there might need to be a metal sheath or stent that will be able to hold it open longer. So in the top right corner, they have pictures, and this is the bottom one, where they have this wire mesh to be able to maintain that opening. Typically, your clients, once they have any type of procedures like this, when they come back, usually right from the procedure, we will not be seeing them immediately, but by the next day, we will be able to work with them. Sometimes we have to just be cautious where the insertion on that femoral artery, that lower extremity, can be uncomfortable. We do need to progress slowly with activity as they are still monitoring the clients with all their vitals. A coronary artery bypass graft is done if there is a unable to resolve the flow of blood for a coronary artery. And so you might see, we call it a cabbage, and you might see cabbage times 1, times 2, times 3. So that indicates how many arteries needed to be either bypassed, meaning they took a artery from another part of the person's body and took that and put it in onto the heart. So here, when this procedure is done, the chest is opened up surgically, so the client does have a sternotomy. The rib cage is then spread while they're able to complete the procedure, and then they close it up. Here, our client will definitely, any type of procedure that requires opening of the chest, we will automatically have sternal precautions that our clients need to be taught and utilized for the next 6 to 8 weeks. I'll go over those with you at the end of this PowerPoint. Sometimes if the client has difficulty with being able to maintain a regular rhythm, they might be required to have a pacemaker, which is a device that's internally surgically implanted into the client, and it has wires that run to the heart, and they have small electrode impulses that can help set the pace for the heart by providing it with an electrical conduction. Sometimes a client will require a defibrillator. It's specifically called an implantable cardioverter defibrillator, and this is used for clients that have cardiac arrhythmias, and this will also help pace the heart, but it will also provide the heart with a high energy pulse to be able to reset it. So if a client's heart was to come to a stop, it would automatically give that high energy pulse to re-trigger it back for that person. It keeps, there's a tracking system with it where it's documented if any abnormalities do occur. The physicians are able to download the software to be able to determine when and how often and how long this is going on with the client. Other surgical procedures, there's cardiac ablation, which basically is going to go in, so the heart might have dangerous signals that are causing the heart to have abnormalities with their contractions. So this small catheter goes into the heart, and it's going to then localize where these abnormal sites are and then actually destroy them. Some of our clients are going to possibly have to have a heart transplant where a healthy tissue and organ from a deceased person is harvested and then implanted into that person. Sometimes while this process is being taken place, while the client is waiting for the heart transplant and their heart is going into failure, they might require a VAD, ventricular assisted device, where a machine is providing complete heart support. So it's a total artificial heart. It's mechanically operated and supported, where it's pumping blood mechanically. And then the last one is a valvular plasty procedure. This is if any of the valves are impaired due to stenosis. Again, similar to the arteries, a balloon can be placed in and inflate that damaged valve, or the valve might be too damaged for that to work, where it might need to be replaced. If this does occur, there's two forms of this type of procedure depending on the severity of the situation. It can just consist of a small incision and them going in and working on it, or it will require a sternotomy to be able to open the chest to get in to replace the valve. Again, keeping in mind that this will require sternal precautions post procedure if it is the second event. With all of this said and done, this can be a very emotional, draining component for your clients. They will have psychosocial considerations, being concerned of overdoing it and anxious of any simple side effect or shortness of breath or a possible chest pain. They could be in denial that this is serious and actually not follow precautions. They could be angry and why is this happening to me, and snap and just not be able to handle the current news and situations. They might isolate themselves or feel depressed because they are not able to complete their roles and activities that they were able to before. But with proper education on the diagnosis and risk factors, we're able to work with our clients that they'll be able to do things, but it will be at a different pace. We'll be modifying their ADLs, IADLs, and return to work. We will be simplifying their activities, pacing them, using energy conservation techniques, using durable medical equipment. But this psychosocial component is really more or less providing them with support groups or coping mechanisms due to this change in lifestyle. As far as the occupational therapy evaluations are concerned, we always continue with our chart reviews. Then we have our occupational profile. We make a lot of observations with interviews and observing them through an activity, allowing us to develop a therapeutic use of self, a relationship with those clients where they feel that we are aware of the situation, knowledgeable enough, and that they feel safe to work with us. The cardiac floor is not a floor that, students are just kind of placed into our brand new occupational therapist in settings, depending on the setting that you're at. But especially for acute care, there's a cardiology floor, a telemetry floor where there's constant monitoring, there's ICU, and this is a trained floor to make sure you are aware of all these medications, cardiac precautions, medical procedures. So again, with practice and knowledge, but we want to make sure that you're provided with all the information right now to be an entry level with further education and training. As far as vitals, they need to be monitored throughout the course of recovery, no matter what setting you're in. In a hospital, we have more our machines are battery operated, and they take vitals immediately for us. In a outpatient and home care setting, that's when you'll be doing more manual blood pressure readings. But sometimes in rehabilitation centers, we will also do more manual ones because they are more accurate. You're going to be learning how to do the Borg rate of perceived exertions. I'm going to upload, there's an OT My Spot that talks about this, and then I'm also going to upload an OT Miri video that's going to discuss MET levels for you, and then I will provide written information and possible Borg rating information for you as well. We will be going over vitals, Borg rating exertions, and MET levels during our lab component next week. So what are the functional limitations that we should expect to be able to see with this diagnosis? And the client will have limitations in their ADLs, IDLs, work, health management, all occupations that they are experiencing. Mobility impairments will most likely be present initially, again, depending on which diagnosis and what procedures were done. We have to be careful of restrictions that are requiring weight bearing for upper extremity usage, which can make transferring bed a little bit harder, as well as functional transfers. Your client will fatigue with very little activity. Their endurance level will be decreased. They'll have more shortness of breath with activities or at rest. They might have a limited tolerance for sitting, and then as we progress from there, as well as standing. So we really need to make sure that we're grading the activities appropriately while monitoring their vitals. And especially if they are receiving oxygen, that can also limit a client's ability to move around a place, and we'll go over that with the next few slides as far as management of those. Some clients will have lower extremity edema, so we have to work on using compression stockings, as well as air compression boots that might be on them if they're at a medical facility. They are at a higher risk for falls. We need to follow all cardiac sternal precautions. Again, being aware of that psychosocial component, and there will be specific contraindications for some exercises. For our interventions, again, want to meet with the clients. What are their personal goals? We want to base it on their present status, what their response to activities are, and with their diagnosis and prognosis, we want to keep all of that in mind. It's also important to educate our clients. That every single one of your clients, every single day, you should be educating them. And if they are on sternal cardiac precautions, you want to make sure that they are able to list them off to you independently, as well as demonstrate them to you. The gradation of activities is very crucial, using that task activity analysis to make sure we find that just right challenge with our clients, and educating them on the signs of fatigue and what to look for, and then the importance of rest breaks. We want to make sure that whatever equipment we provide them with, we not only educate them on them, but we explain to them why it needs to be used, because of course sometimes the equipment might take them a little bit longer to do things, but what the client isn't realizing, it's decreasing the exertion on the heart, depending on if they versus bending forward, right? To do lower body ADLs, we would give them adaptive equipment because of all of that unnecessary exertion and pressure that will be there, as well as the precaution. We want to make sure that we teach them pursed lip breathing techniques and energy conservation techniques, and being able to pace themselves with time management skills for an activity so that they don't tire out so easily, that they're able to pace themselves and successfully complete an activity. We have to be really careful with any type of dietary instructions, continuous weighing of themselves depending on what setting they're in. Especially if they're on diuretics, we need to make sure that we are aware of their toileting needs and their safety and their abilities based on their current situation. Managing O2 lines and O2 equipment, being able to realize if we can maneuver just using, if they're hooked up to oxygen in the room on the wall, we would need to get extension lines for the O2, nasal cannula O2. And then if they're going to be ambulating outside of the room or into the bathroom, we need to get a portable oxygen tank to be able to maneuver those, to know how to work them, to set them to the right settings. Working with health management, addressing medications, making sure they're taken correctly, the correct amount and on time, and most especially that client and family education. Because with Rudy, the biggest issue is the wife was so concerned of the client being able to return to their everyday self-care, intimacy, and so forth, because she was so worried that it would affect him in a negative way with his heart. So proper education and training is crucial. Some of those cardiac sternal precautions that I was telling you about, they could last for 6 to 8 weeks. We need to make sure that the clients are aware of this. We do not want them pushing or pulling with their upper extremities, which makes bed positioning really difficult with rolling and going from supine to sit. We really don't want them to put too much weight bearing into their upper extremities. No lifting over 5 pounds. Remembering that a gallon of milk is 8 pounds. We want to make sure that there's no excessive twisting of the body. They really shouldn't be lifting bilateral upper extremities at the same time, most especially not bringing them up past 90 degrees for shoulder flexion and abduction. We want to encourage them holding on to a pillow. Sometimes they're provided one post-surgery, or they can have an extra pillow in their room to hold at their chest if they're feeling to cough and if they're going to be moving, to prevent them from using those upper extremities. ICD precautions. We want to make sure that, again, there's no exercise involved with that left shoulder. We want to minimize any weight bearing when using mobility equipment for the upper extremity. So again, thinking about, having to use what type of walker. We would want the one that was most mobile, no lifting whatsoever, so we would never use a standard walker. And if they are using a walker or cane in the opposite extremity, if they're using a walker, educating them how they really need to put most weight onto the opposite side, no lifting again, and no driving until cleared from the surgeon. This is a video play it for you because it doesn't record for a PowerPoint, but I will upload it for you so you can watch it at your own time. It's a short 6-minute video. It does a great job explaining the circulatory system of the heart and the oxygenated and deoxygenated blood and all of the terms to help familiarize yourself with the heart and its anatomy. If that first slide was really difficult, this is a nice video to watch. Again, a reminder for next Tuesday, there has been adjustment to the schedule due to the snow day, so you want to make sure that you come in for 11:30 to 12 so you can take your quiz 1. From 12 to 12:45, we're going to have our cardiac disease lab. You're going to be working on assessments and interventions. Our assessments are going to be taking vitals on your partners as well as the Borg assessment. Your interventions will involve case studies, going over intervention plans, as well as MET levels. So please make sure that you bring your OT kit with you when you come to class next week. So we're tapping into the morning, and then we'll get a 15-minute break, and then we'll go into our regular lecture and lab time, and that's going to be on pulmonary diseases. We did want to provide you with the names for the study guides for the next rotation. It is both on cardio and pulmonary. So some of you are going to have the cardiac ones, and then some of you are going to have the pulmonary diagnoses. So those are listed here for you. And again, if you have any additional questions, please feel free to email me, and look forward to seeing you in class next week. And don't forget the time change, and don't forget your your OT kits. Have a good night.